test, when you read the question, if you know healthcare terminology, half the time you already know what the answer is. Because the word will tell you what the answer is a lot of times. So again, understanding healthcare terminology is very, very foundational. You do it well in those ABC tests, and then of course in here. So the first thing we're going to talk about are planes and ways that we divide the body so that we can talk with other people pretty clearly about which parts of the body we're talking about. The first two planes we're going to talk about are really somewhat similar, but just a little different. Our median plane is a line that's essentially passing directly through the middle of the body, dividing the structure into equal right and left halves. A sagittal plane is also a cut in the middle of the body, but it may not cut into an equal left and right half. Does that make sense? So a median plane is sometimes mistakenly called the sagittal plane. So we need to understand the discrepancy and the difference between the two. This is really the mid sagittal plane or the median plane. Those are AKAs of it. You need to know them both. The mid sagittal or median plane, they both mean exactly the same thing. You need to be aware of both because when you go to take your NBC test, another school may use mid sagittal instead of saying median plane. Does that make sense? And we all write those questions for the NBCs. So as we send those in, maybe there's different terminology that's being used and we need to know what that is. The sagittal plane, again, it's dividing us into a right and left portion, but it may not be equal. Another name for that sagittal plane, there could also be a parasagittal plane as well too. So again, there's different ways of talking about it. We need to be careful with this, right? Is this a sagittal plane? This guy right through here, this line right there, is that a sagittal plane? Yeah. It is. Coincidentally, it's cutting us into a right and left half. So what would be a better name for it? Mid-sagittal. Because if I use the term mid-sagittal with another healthcare professional, they know I'm talking about an equal right and left half. If I use the word sagittal, maybe it's equal, maybe it's not. Does that make sense? So that's the difference between those terms. Frontal plane versus transverse plane. Just take a look at it. The coronal plane is also known as the frontal plane. Okay. There's this movie called 13 Ghosts. It's like this old horror movie. This guy's running through a glass house. Everything's glass. He gets to the doors. The doors shut on him before he gets all the way to the door. He cuts them to a front half and back half. That's the frontal or coronal plane. Okay. So the frontal or coronal plane is dividing us into a front or anterior and a posterior half. The transverse, this is the one that's heading us with top, or excuse me, right in the middle, right across. This is one of the planes that we commonly see whenever we're looking at an MRI. MRI images typically are taken from bottom to top, so normally we start at the feet and working transversely through the actual body itself. But of course, we can also see them in the sagittal plane as well too. We okay with those different planes? Frontal, coronal mean the same thing. Transverse plane, okay. Could say transverse, horizontal, above two, cutting across. Superior is pointing up, right. Inferior is pointing down. Lateral means we're going which way? Lateral normally means we're moving away from our belly button, right? Like we're moving to the side, away from our belly button. Medial normally means we're moving to the towards our belly button. But what if we're talking about just the hand? Because this is abduction. Abduction is me moving away from the body. I'm moving abduction, right? Okay, so moving away from the body. But if I open my fingers into abduction, I'm opening my hands up. This is actually moving towards the midline of my body, right? So is it still abduction, or is it abduction, which is adding to the body? It's still abduction because now this is my point of reference. This is sort of like the belly button of the hand. Okay, so moving this way would be abduction because I'm adding to my hand. Even though technically, if I do that, it goes away from my body. Does that make sense? So normally, when we're talking medial and lateral, we're talking either away from the belly button or towards the belly button. But if we're talking about something like our hand, the belly button you can think of as being right here in the palm area. And so abduction would be moving away from this belly button, and then adduction would be moving this way. If you break that up into being right beside your body, that can be confusing because abduction actually brings your feet closer. So again, when we think medial versus lateral, remember we want to think about what tissue we're talking about as well too. So we've seen lateral probably last term, we've seen medial last term, but you will get questions sometimes about, the abductor takes the finger which way, and technically it brings the finger this way, And if you're thinking belly button, then that's going to say, okay, it's moving medium. But the belly button is where? Here. Right here in the palm. Okay? So again, it actually would be taking it flat. Does that make sense? So that's really confusing. Simple is away from belly button, toward the belly button. But if we're talking about individual hands, then that changes the conversation just a little bit. Deep means we're moving into essentially away from the surface area. Superficial means we're getting closer to the top. Proximal means we're getting closer to the trunk. Distal means we're getting farther away. So if we're looking at the humerus, this is the proximal part, right? Up here towards the glenohumeral joint. As I move closer to my digits, my finger, this is the distal part of the humerus. Does that make sense? Yes? Say that again. The trunk is referring to this. I look like a big tree trunk, big fat trunk. Okay? So moving closer to this, moving closer to the body. But each body part has its own proximal versus distal. So if I look at this bone right here on my pinky side, this is my ulna. This is the proximal ulna, and then this is the distal ulna. But this is the distal humerus, and this is the proximal humerus. That makes sense? So each bone is looked at individually as well, too. So as they move closer to the trunk, that means proximal, and then distal is getting farther away. Here's just a quick pictogram so you can see those as well, too, just to help you. I like pictures. Sometimes I like to just put a picture up and we just talk through the picture. But normally you have everything written out there. Medial, lateral, we just talked about that. Bilateral. When we think about bilateral, we think of just things that exist on both sides of the body. So what are some examples of things that don't exist on both sides of the body?
Liver. The liver.
Appendix, liver, spleen, ring finger, but you have two. So
Brain.
But you can't wear it on both, right? Yeah, you can't wear it on both. So those would be bilateral. Are you bilaterally symmetrical? No, right? Most of us are not bilaterally symmetrical. Our right arm might be a little longer than our left arm might. Okay? Maybe our right femur is a little bit longer than our left femur, but our left tibia makes up for it. It's a little longer than our right tibia, so we actually look like we're standing upright. When it comes to bilateral symmetry, we have to sort of keep that in mind because we adjust the patient's blood on what do chiropractors frequently use to indicate leg strength. Well, is there an anatomically short leg that's causing it? In that situation, possibly. Can you still use leg checks in someone who has an anatomically short leg to evaluate the adjustment? Yeah, but in this situation, you're looking for change. So maybe one leg's here, one leg's here. It could be that this is probably not going to be this big of a discrepancy. But it could be. I had a friend of mine who I came to the program with, he had a discrepancy that big. He wore a heel lift in the other shoe to balance that out. In this situation, what we would be looking for is a change whenever we do anything. And does it go longer or does it go shorter? Does that make sense? So you still can use that, but you want to be aware of it. Does that make sense? So as part of your physical exam, you might use that check to make sure that the pelvis is lined up and that the legs actually are symmetrical, so that when you're looking at that leg with discrepancy, you would use that as it really should be to evaluate the changes before you make those adjustments. Okay? So again, remember bilateral, it really just means that it's the same on both sides of the body, but let's just be careful with that word same. That doesn't mean symmetrical. There could be like some asymmetry, but it exists on both sides. Unilateral, we just said spleen, liver, appendix, things like that. Ipsilateral, two separate structures, but they're on the same side of the body, right? My right leg and my right arm, both on the same side of the body, two separate structures. Contralateral, these are two separate structures on the opposite side of the body. Cephalad means we're moving towards the head, and cortical means we're moving towards the tail. What's your tail? Moving towards the coccyx. That's right. So the coccyx is sort of our tail. Again, just another pictogram so we can see it sort of divided out. Feel free to take time looking at that. Patient laying face down, patient's laying wrong. Patient laying face up, spine. There's a test we do in neurology called diadochokinesia, which means that we just check to see whether or not the brain is coordinating with motion on both sides and do really fast. Really all we're doing is doing pronation and then supination. The way I remember supination is it's like I'm asking you for a bowl of soup. Can I have a bowl of soup, please? My hand's out right, so this is supination. I don't like it, so I pour it out. Okay? Supination, pronation, This test is just supination pronation. It was maybe the second OSCE exam. Student intern reads the patient. They lay the patient on the table. They get diadacokinesia as one of their tests. They ask the patient, "Can you lay on your back for me? Can you lay on your stomach for me? Can you lay on your back for me? Can you lay on your stomach for me?" What were they doing? They were pronating and supinating the entire patient like a fish, flopping back and forth. I couldn't control my laughter. I mean, it was ridiculous. Like, they literally had the patient flopping down on the thing. It was really hilarious. I loved it. Those exams you guys take, they're all recorded. So late on a Friday night when I've got nothing to do, I pull them off, popcorn, and start laughing. You guys will be amazed at what you will do during those tests. I've had people like touching this part of their body. Okay, this is vulnerable here. Okay, this is the ear. This here. And you'll be amazed. And then you'll argue with me too. You'll say, like, Dr. Lunsford, I never did that. I know I didn't say that. And then I'll pull up the video and say, well, just take a look. And then you just be able to, okay, I'll have to retake this class. I'm just joking. I don't ever do that. I never like to go back in that. But sometimes I do have to control myself. Pronation face down, supine face up, anatomical position. This is a weird question that sometimes will show up on your NBC test. You're never going to forget it after today. It's weird. In the anatomical position, the body's like this. Okay? For the male, the anatomical position of the penis is considered cephalad, or it's considered the correct position. So sometimes you'll get a national board question which will ask you specifically in the anatomical position. I remember the first time I taught this, somebody came up to me and they were like, "Hey, Dr. Lunsford, I mean, my point, I don't know what you're I forgot to say it was in the erect position. It was in the erect position. Once I had that clarity in there, but okay, well, I was like, "Yeah, I know you." So again, we asked that on the sheet. It's funny, it's easy to remember, and unfortunately, things that are vulgar are easier to remember, right? So I hate to say it. And one of my anatomy teachers was like this sweet old lady. She was like my tall, she was really sweet, nice lady. And she would drop all these like vulgar like things on that whole time. And I never forgot any of them. Never forgot any of them. What's the function of your skeleton? What's your skeleton do for you? Supports muscle. Hold your body up. It protects the vital organs. It protects vital organs. So we have all these ribs that are protecting our lungs, our heart, big breastplate in front of it, protecting our heart there. There's also the formation of blood cells as well too, which is called hematopoiesis. What's the difference between hematopoiesis and erythropoiesis? Hematopoiesis means we're referring to the formation of blood cells in general. It could be white blood cells, it could be red blood cells. Erythropoiesis means we're specifically talking about erythrocytes, which are red blood cells. Okay, so again, hematopoiesis is one of the things that the bones do for us. They form new blood cells. But again, it's not just red blood cells. So hematopoiesis is referring to all blood cells. Erythropoiesis is specifically speaking to the formation of red blood cells. Mineral storage and homeostasis. In order for my heart to contract, there's this slow release of calcium through these little leaky channels that allows the spontaneous contraction of the heart. It's not really spontaneous, it's really regulated, but we think of it as spontaneous contraction of the heart. Now, the calcium is just slowly leaking until eventually it causes a certain electrical potential change, and then the heart contracts. Okay, and it keeps happening over and over and over. So in order for my heart to contract, what do I need? Calcium. In order for neurotransmission to take place, in order for your body to release the neurotransmitters, what's called the synaptic tract, the space between two neurons, you need calcium to facilitate that release. In order for the motility of your digestive tract, in order for your muscles to relax, you need calcium. So your body stores a large portion of calcium inside of our bones so that in times of need, we can cannibalize that bone and release that calcium in the blood. Okay? So again, this works as mineral storage as well too that helps maintain homeostasis. So if my body, say my hypothalamus pituitary axis, discovers that maybe there's not enough calcium in the blood, it will cannibalize my bone, release that calcium in the blood. if I have an osteolytic cancer. What does lysis mean? It means to break down. So if I have osteolytic, I have a cancer that breaks down bone. So if I have an osteolytic cancer, I'm breaking down bone. So I would see increased levels of calcium in the blood. Remember, there's also phosphorus that's attached to that, and so we'll also see the phosphorus levels go up. We can use that marker in the blood to tell us if there's an osteolytic lesion or an osteolytic cancer that's happening in the body. So we can utilize this in different types of evaluations to detect whether or not there's a problem or pathology. But for us at this point, we just need to know that, that bone works to help store these different minerals for our body so that we can function. When we look at the body or the skeleton itself, it's divided into an axial and appendicular skeleton. Next quarter, when you take axial anatomy, it's really gross one. The gross one is really axial anatomy. We'll start off by looking at the head, the neck, and we'll go through the back muscles, and we'll go through the spine itself in gross one. In gross two, you'll essentially be doing this, the appendicular skeleton. Gross two, essentially that. We need to know how many bones there are in the body. We need to know how they're divided amongst the axial and appendicular skeleton, because sometimes your QBC questions will be as simple as saying how many bones are in the human body. Okay? And we'll say 206 generically. Could a person have more than 206? No. Yeah, some people do have these digit. There's also the formation of these bones that we call sesamoid bones. They're called that because they look like a C, and they develop inside tendons, especially areas that are high friction. So a person can have more bones than they're supposed to have. Okay? So again, a patient or a person may have more than those, but that's sort of the standard answer. If we say 206, we're good, no worries. Again, here we can just say a nice little pentagram. In order to talk about bones quickly, we divide them into these different sort of classifications of bones. A long bone doesn't necessarily have to be long itself, like my humerus is a long bone, but also my metacarpals are long bones as well too. So when we think about the classification of bones, it's really about how they develop, more so than it is how long they are. So again, my femur is obviously that's a long bone compared to other bones, but my metacarpal, which is much smaller, which is like really only from here to here, it also is a long bone. Okay, so again, it speaks more to how they're formed. A short bone typically is going to that's going to be somewhat square shaped. So there's a bone in my foot called my cuboid. Not surprisingly, it's a cuboid shape, and it's a short bone. Flat bone, when we think of flat bones, we're thinking of something called intermembranous ossification. We don't need to know that just yet, but it's intermembranous ossification. And so typically we think of things like our skull. Our skull actually has a lot of flat bones that are very thin, but you could also think of something like your sternum. The sternum is very flat bone as well too. Irregular, these are the ones where you get really familiar with as we go through our adjusting boxes. Those vertebra, some of our facial bones are like that as well too. Then of course the sesamoid bone. The major sesamoid bone that we typically think of is the patella. The patella develops inside something known as the quadriceps tendon. So it develops into something called the quadriceps tendon, and then ultimately is attached to the tibia via the patellar ligament, because it's bone connecting to bone, even though sometimes we'll see it referred to as the patellar tendon. Here's just an example of the bone that you can see there. This is the patella itself. Nice anchor point of quadriceps as they anchor down into the tibia. On each of our bones, there's different markings that we're going to find, and those markings typically correspond to something either passing through it or possibly a marker of something that person did throughout their life. You guys ever seen the TV show Bones? Like the forensic anthropologist who goes through, they look at murder victims and they use the markings on the bone to see who the person was. Well, that's real, and as we use our body, we definitely cause our bones to sort of change. So as we're maybe going to the gym every day, let's just say we just do bicep curls every day of our life we do bicep curls. Well, there's a very good chance at the end of life, when you look at the skeleton of that person, they're going to have these very big bumps where that muscle is attached to the skeleton. So bone itself is a dynamic living system, and if you put stress on it, it'll respond by increasing in thickness and maybe even grow in size and direction. Does that make sense? So if you're taking something like our bicep, which is on our radius, and we keep pulling and pulling, there'll be a big bump on there called the radial tuberosity. It's also known as the bicipital tuberosity. And if you really use it all the time, that bump will be really, really, really big. But if you were really small and frail muscle, then it would be nice and swell. Does that make sense? So the markings on our bones will also correlate to some of the different activities we did as well too. Now, we also see it, like I said, when a structure is passing through the bone. And then the shape of these bones and the markings on the bones can help influence the direction of movement of the bone. So if we look at the head of something like the humerus, if we look at the head of the humerus, it's got a nice circular shape to it. That allows for me to have a lot of mobility of the shoulder joint, also known as the glenohumeral joint. Okay, so I can move it from the frontal plane to here, the sagittal-femoral plane to here. Okay, so I can move it in all these different directions, right? If I move my arms like this, what motion is this? Abduction. And I always emphasize that second letter so you don't confuse it with abduction. Just because I'm Southern, I have an accent, right? So abduction, you don't have to say it that way. I just say it for clarity. Abduction is this. And then when I add to my body, it's adduction, okay? So when I do this, abduction is technically like 180 degrees that happens because of the shape of the humerus, the mobility of the scapula. And then as I bring my body like this and I cross over, there's about 50 degrees of motion happening. Okay? Abduction, abduction. What about this? What is this called? I'm coming up like I'm on a roller coaster. This is flexion. So I'm moving into forward flexion of the glenohumeral joint. That's how I describe it if I were taking a test or something like that. And as I move back like this is extension of the glenohumeral joint. Okay? I have a lot of mobility in this joint because of the shape of that humerus, and then also the mobility of the scapula as we move through that range of motion. Whenever we have a joint that has a lot of mobility, it's got a greater risk of injury. Anybody here have a shoulder problem at some point? A lot of people. Most of us at some point in our life we hurt our shoulder. Okay? And that's because there's so much range of motion. But the shape of the femur is the same. It has a nice ball. Why don't we hurt our hip joint or femoral scapular joint as much as we do our femoral joint? Like it's a deep socket, which creates more what? Stability. Creates more structural stability. So even though there's the potential for a lot of motion if you're very flexible, there's so much supporting tissue and the fossa, or the place that it fits into, is much deeper. It creates more stability. And most of us can't take our leg and put it all the way up over our head, right? Some of you guys can do that, right? But most of us can't do that, okay? And if you can do that and you want to be more flexible, you could like buy machines that like put you in those positions. When I used to teach Friday, I had one of those split machines because I had to do a split. But I'm not very flexible. So for about every day, 2 times a day, for 6 months, I used that machine. So eventually I have to do a split. And I could get all the way up. I was using the machine and it broke. But my muscles hated it. They couldn't stand it. They were fighting it the entire time. How long do you think it took me to go back to my normal range of motion? Maybe like 2 months, maybe about 4 weeks or something like that, and I was still training. So it's kind of interesting, like if you're not super flexible, you can train yourself to become flexible, and you can also lose it if you stop moving up really quickly. So again, the shape of the bone itself dictates that motion. Do you see this landmark right through here on the spinal bone? That landmark right through there is called an articular process. If something's called articular, it probably lets you understand that it's going to articulate with something. Does that make sense? So the superior articular surface here is going to articulate with the inferior articular surface of the bone above it that allows motion. The shape of these facet joints, which is another name for the articular surface here, determine what kind of motion can happen in our spine. So again, the landmarks that we see on the bones themselves, we learn how to identify all those. We also need to understand that those surface markings can also dictate the type of motion that's going to happen. And for the spine, what determines the directionality or the amount of motion that can happen are those facet joints. Now there's some terminology that you need to know. I'm not going to read this list off to you. We'll talk through these terms as we're going through, but you have to learn all these different terms. Last quarter, you got the healthcare terminology, is that right? So you probably have a system in place for how you learn those terms. When I came through, Quizlet wasn't quite like the thing yet, so I actually used index cards, and I had like rings and rings and rings of index cards, and I just was real true. When you go to those cards, or when you go to your Quizlet, and you come to terms that you know cold, that you can say in your sleep, what should you do with those terms? Take it out. Why waste your time studying something you know? And as you're studying, what does the list suddenly start to become? Smaller and smaller and smaller. So you're really only practicing the stuff you're not sure about. Does that make sense? I used to always start from like study section A and only go to study section Z. So everything in the middle, I totally would forget. And then someone told me, they were like, hey, Billy, why are you spending all this time studying this big chunk of information you know? You could wake up in the middle of the night and answer a question from it. And I started moving those out of the desk. For me, it was index cards. And now all I had left was these terms that I really struggled with. They got smaller and smaller and smaller until I was able to make one of those steps. So again, don't spend your time studying stuff that you know really well. Instead, try to concentrate on studying how you know it wrong. Now, whatever you think about these terms, whether you like them or not, you have to know them. These are just the basic terminology we'll be using as we go through osteology. Again, I'm not going to go through all of them, but I'm going to highlight some of them. We just said a minute ago that this was a what? Let's see, a facet, but we also said it was a articular process, right? So we could call this the superior facet, or we could call it the superior articular process. When one bone meets another, they form this nice little joint. We call that a facet joint. It's also known as a zygapophyseal joint, big word. And then we also sometimes abbreviate it by saying Z joint. So sometimes when you see these put together with another bone, and we'll talk about that as we get into the joint classification, you'll see it called any number or combination of different words. But a facet is typically a smooth, flat, slightly concave articular surface. And we said that the facet joints in the spine will determine what kind of motion you have in the spine. Now, what does that mean for us as chiropractors? So think about it. One of the major influences we exert on a patient is duty of touch. It's one of the big things we do, right? How are you going to adjust each one of these segments? Because each one of these bones, the articular surface, is going to be at a different angle. So what does that tell me I have to do differently for each different segment in the spine? I have to adjust my line of drive, the line of correction, however you want to say it. So as we're adjusting our patients specifically spinally, we have to understand the different angles of those facet joints so that our line of correction is facilitating that motion. Yes, sir? So that's a great question. So here's the thing. There's standards. And we'll go through the standard like angles and measurements that we use for a test. But you're going to find that that's different from patient. So each person, maybe because of their height, maybe because of the load of their life, their body will adapt differently to those stresses. And so sometimes there will be different. The best way to understand the motion of someone's spine is through motion palpation, which will be one of the factors you guys will take in understanding the actual movement. So we'll talk about like the general angles of those different facet joints, but as you get into your adjusting classes with your palpation classes, specifically motion palpation, you'll learn how to evaluate from patient to patient because it will change a little bit how you set up. Yeah, so if someone has something like a hyperkapnosis, like their back is really like this, that won't necessarily change the volume landmark initially, but over time it will. That makes sense? All is kind of slow to change. Anybody in here have braces, like when you're older in life? I had it when I was in my 20s. I had to wear it for like 5 years. So that's the bone already set, and so it took a long time to pull it back. If you're older when things happen like that to your bone, it typically takes longer for that change to happen. Same thing when we're adjusting our patients. So if we're using something like chiropractic biophysics to try to get the spine to a specific shape and curve, that can take a lot longer if we're dealing with older patients because the bone has been set in that position for a long time. It won't necessarily change the generic development of those facet joints, but over time it could lead to some performance. Yeah, so those can change. So again, our line of correction is somewhat going to be dictated by this. There's a great picture out there. I need to find it and still it. B.J. Palmer sitting at a chiropractic table with a spine that has all these long lines coming off, so you can see the different line of all the facet joints that as it goes through the spine. Next time I see it, either on Facebook or Instagram, something I'll still know how many classes. But it just shows you how you have to change your setup on the patients. One of the first times I was doing jiu-jitsu and I was learning how to do that, I remember I had the instructor who was showing me how to do like basic arm bars, and I had his arm, and I was just pulling, and he just looked like he was having a cup of tea over there. And eventually I was like, okay, what am I doing wrong? And he's like, well, you have to turn this just a little bit, and you have to move this there. I made these two very tiny spinal correction, when you try to do the adjustment, it'll be painful and uncomfortable. Okay? As you begin to learn that line of correction and the way it should be, it'll be a nice, smooth adjustment and it won't hurt. Okay? I'm not going to say it won't always hurt because there's inflammation of the joint and you do adjustments to the body and discomfort. But again, it won't be because you did a bad setup. Does that make sense? Who in here has had a bad setup on them? I've had a bad. It's painful. And it's actually, I remember the first time I got adjusted, it was so painful, I almost just put my back together. So that's a different story for a different day. This big giant guy named Matt was I took my head, took it one way, and then he grabbed it and took it the other way, and he was like, that last one was free. And he walked off like he was conquered earth. And I remember just being stunned and silent, just sitting there. I had a body experience. He didn't tell me it was going to hurt. He didn't tell me it might be sore. I don't even know that he did it. He dislocated my neck from my body. Okay? And I remember the rest of the week, I was in so much pain and discomfort. I literally almost didn't pursue chiropractic after that. It was pretty intense. All of these different landmarks on the bone, again, you're going to have to go through. You're going to have to learn the terminology. I will be teaching you these as we go through, but I'm going to use it as part of our regular communication. If you're trying to learn a language, what's one of the best ways to learn it? The Pat said in that country. I was on a trip to Peru. It was a service trip at the seminary I was at. One of the people, they fell on the last day and they broke their hip. And so I ended up having to stay in Peru for another couple of weeks. And after that, maybe another week of being there, I was able to go into the restaurants and I was able to order my food. I was able to walk and see. I mean, like, I picked it up. I've been using Duolingo for the last 3 years. And my Spanish is still okay. It's really bad. I learned more from that 2 or 3 week trip than I have in the last few years. So you're now like in it, right? You're in the language. And so we're going to be using it conversely, and that's going to help you accelerate your knowledge and understanding of it. Even if you don't have a strong science background, by the time you get to third and fourth quarter, you're going to feel really comfortable with learning this stuff. Anatomy really is its own language. Let's talk about some of the basic anatomy of the different bone bones we have in the body. The bone portion that we see right through here is known as the diaphysis. You could also call it the shaft of the bone bone, but that sounds a little creepy. Okay? So instead we say it's the diaphysis of the bone. The diaphysis is this long portion that we have right through here. The diaphysis typically is where we find the bone marrow, where things like hematopoiesis takes place. The epiphysis is found at the ends of the bone. So there's 2 epiphyses. There's one at the top, which is the proximal epiphysis, and then there's one at the bottom, which is the distal epiphysis. And if you look at the epiphysis, it's covered with articular cartilage, letting you know that that's the point of articulation with another bone. So again, on either end, typically of a long bone, you're going to find articular cartilage. All articular cartilage is hyaline cartilage. Okay? So if we see the word hyaline cartilage, we know we're talking about articular cartilage, and that's what communicates with the next bone in the list. The metaphysis is somewhere between. The metaphysis is this gray area sort of underneath this line. It's known as the epiphyseal line. The epiphyseal line is the epiphyseal growth plate of the mature skeleton, and that's where the length of growth happens in a long bone. It happens typically in the metaphysis. So it's this area of mature bone for the adult, but for the growing bone, it's an area for a place called the epiphyseal plate. And that's where growth of bones happen in length. Okay. When we grow in the length of a bone, that's called interstitial growth. Inter, like I-N-T-E-R, interstitial growth. When we grow in thickness of a bone, that's called appositional growth. I like to think of an apple as big and fat, and that's how I remember appositional growth was like growth in girth, like the size of the diameter of the bone. We have given the difference between the diaphysis, epiphysis, and metaphysis. Why do we need to know that? We partially need to know it because as we get into our radiology class, we're going to learn that certain tumors have a predisposition for only attacking one part of the bone. Some will only attack the epiphysis, like an aneurysmal bone cyst will normally only attack the end of the bone. Okay? Some of them will only attack the diaphysis, things like a Ewing sarcoma will only attack the diaphysis of the bone. You'll see the growth changes in there. So we need to know these different regions for that reason, and then also, of course, the children. Articular cartilage, we just talked about that. The articular cartilage is what we see at the end of the bone where it's related to another bone. It's always going to be, or at least we hope it's always going to be nice and smooth. Where 2 bones meet, do the bones actually touch each other? No, ideally not. If those 2 bones are actually touching each other, that patient has a lot of life. Pain is pretty terrible, but it's also really awesome. It's really awesome because if you don't have pain, you probably won't have a very long life. If you don't experience pain when you step on the nail, you won't know that it's a nail. And you won't know that it's getting infected. You won't know that it's becoming gangrenous. You won't know to go get that treated and taken care of. You'll lose your leg or you'll lose your life. Right? So pain from that point of view is very informative. And it tells us, hey, listen, there's a problem. You need to take care of this. And it will become so loud that you can't ignore that pain. Right? Who in here is good at ignoring pain? Most of us probably at this point in our life can ignore pain to a certain degree. That pain is very good at getting so loud that you cannot ignore it. Eventually, you're going to have to get it taken care of. Does that make sense? So again, pain is it's kind of a gift. But at the same time, if pain is left unchecked, what can that lead to? It can lead to maybe deformity. Normally, if something's really, really painful, you won't move it. Compromising. What kind of compromise are we thinking? It could be a compromise with your goals, or maybe you don't like the idea of taking drugs and medication. You're in so much pain that God help me, if I don't get help, I'm going to kill myself. Okay? Anybody ever been in that kind of pain? It's pretty horrific. I remember breaking my rib one time, and I remember trying to move, trying to walk, everything was painful. It was terrible. It just, you don't realize how important that rib cage is. All the different components to move, all the force to move. But if a patient's in that kind of pain, what are they probably going to take? Probably painkillers, and unfortunately those painkillers are what? They're highly addictive, and unfortunately they can lead to dependency, right? And that's how we land in this sort of healthcare crisis of people being dependent on opioids and painkillers. So they do work to deaden the pain. And in a situation where it's like life or death, maybe they should be taken. If bone is rubbing on bone, it could be that pain, okay, and that patient may not move. One of the best things to help prevent things like degenerative joint disease is motion. So moving is actually kind of life to your body. And when we have degenerative joint disease, it doesn't feel like maybe it's that good of a thing to move, but it actually is really good because it creates fluid moving around in there. It creates some good white blood cells to go in and clean out some of the debris. It creates some of the healing properties that can happen in that area, some inflammation. And so it's a very good thing. Unfortunately, if you're not moving, that's not happening. The periosteum is the thing that surrounds the bone. So around each bone is the periosteum. The periosteum is highly innervated. Typically, when a bone fractures, the major source of pain is coming from a disruption in the periosteum. It's the tear in the periosteum that's sending these pain signals to the brain itself. Or if there's swelling inside of a bone that's pushing on that periosteum, that typically is what's causing all the pain. So there's two layers of it. There's this outer layer where we see lots of nerves, blood vessels, and lymphatic vessels. And then there's this inner layer, which is the osteogenic layer. The genesis, that means the beginning of something. It means pertaining to, right? Osteo means bone. So this is pertaining to the growth of new bone. Does that make sense? So the inner layer, we're okay with new bone being formed, right? On the inside. Are you aware that your bones are growing forever and ever and ever? Okay. We're not growing in length beyond a certain point, right? So we're not really growing in height, but our bones are a living dynamic system that are responding to the stresses that are being placed on them. And so the density or the thickness of those bones are changing as we go through our life. Inner layer, therefore, is going to be osteogenic. The outer layer is not. We don't want bone growing outside the bone. Does that make sense? So the outer layer is not going to be osteogenic, and that's a good thing. So that inner layer is going to contain these elastic fibers that allow for some stretch. Osteoblasts, I want you to think of them as builders. Osteoblasts are our bone builders. Osteoblasts are like, oh, I lost my biceps. Okay, they're like, I'm going to build. Osteoclasts, these are catabolic. Osteoblasts are builders. Osteoclasts are the things that can break down. There's a certain dance that's happening between the osteoblasts and the osteoclasts throughout our entire life. There's a certain amount of bone that's being broken down, maybe because we need some of the calcium being released into the bloodstream. Maybe it's because there's degradation of the bone and it needs to be replaced. And then there's the osteoblasts that go back and rebuild the bone tissue after it's been broken down. You don't want those two systems out of balance. Does that make sense? If your osteoblasts become highly active, you're going to build lots and lots of bone. If your osteoclasts become very active, you're going to destroy lots and lots of bone, and your structure will become unsound. But they both are going to be structurally unsound. What allows a bone to not break under tension? Some of the elasticity. Bones, believe it or not, actually have some elasticity to them, and they actually are somewhat flexible and mobile. That prevents the bone from breaking too easily. Have you guys ever seen trees around here, like strong winds or tornadoes come through? What happens to those trees? They break because they're not very flexible. But you see palm trees by the shoreline, and there's a hurricane coming through, picking up cars going through windows. But what happens to the palm trees? It just fixes itself after a hurricane's gone, and it's fine. It's because it's super flexible. Your bone is sort of a mix between those two. There's a certain amount of flexibility, and then there's a certain amount of rigidity. And that's essentially developed by these fibers, these elastin fibers that are part of the matrix of the bone itself. So again, one of the reasons our bones don't break under a lot of tension, depending on which bone we're talking about, is because of those tensile strength. Now, the periosteum is the attachment site for ligaments and tendons. So, do muscles attach to bones? Or do they attach to the periosteum that surrounds the bone? They technically attach to the periosteum that surrounds the bone. So let's say we're taking a TDC test, and it asks you that question. The muscle attaches to which of the body? And bone is the only option that comes to the center. What are we going to choose? Bone. But if we were given a choice like A is bone, B was the periosteum, which one would we choose now? B, because the periosteum is the most specific answer. And sometimes ABCD will ask questions like that. So choose right answer, or this one's right. Okay, and you have to know which one's the rightest of all the right. Okay? So again, the attachment for ligaments and tendons are happening there in the periosteum. Inside the bone, we have a marrow cavity. This is typically in the diaphysis of the bone, and that's where we're going to see the yellow marrow and the red blood marrow, which we'll talk about a little bit later. The inside of the bone, if we look at it, you see this right in here, this inner layer where the marrow is? If we remove the marrow and we're just standing inside of a bone, if we touch out to the boundaries of the bone, it's covered with this stuff called the endosteum. Think of the endosteal layer as being sort of the wallpaper in a room. Okay? So if we're standing in the middle of the diaphysis of the bone, and we reach out and touch the walls, it's going to be covered with the endosteum. Okay? And this endosteum is the inner layer of cells that lines the marrow cavity. So it's sort of like the wallpaper that surrounds the actual marrow itself. The endosteum contains osteoblasts, and it said osteoblasts do what for bone? They build bone. Osteoclasts do what for bone? They break it down to release calcium. Okay. What questions do we have for this week's material? So it's 8:46. I'm going to tell you in the future, we probably won't go the full time to 8:50. Normally we get out a little bit earlier. Unless you guys are all about fall asleep, you don't take a break. You do like some more dances and things like that. Just remember, as you're going through this program, one thing that happened in this new program is that we've reduced the number of hours you are in your seat. If you're not with me as much, what does that mean you have to do on your own? You got to study. You have to do the reading. You have to start working on projects. As a matter of fact, I went ahead and I put this up for you. So if you go to Blackboard here, you see at the top of the page there, it says structure list for osteology and archaeology. This is the structure list, okay? So you can begin learning the information from going through and start doing the osteology structure list as well. If you were to go to YouTube and type in my name, maybe osteology, and pull up videos that I've gone through and actually essentially done this project, but I've done it in a video format to show you all these structures. You obviously can copy and use that into your document and things like that, but you can use that to help you get exposed to some of those as well. If you have trouble finding those, let me know and I'll put a link under the announcement so that you can find it. Yes, sir. We'll do that at the beginning of next class. If you guys haven't done your reading, and this is like our first meeting, understand that those knowledge checks, those are normally meant to be done like as we first walk in the door, we've already done your reading, there's an opportunity for you to see like where you are conceptually, you look at the result, you can also say, okay, you're doing really well, I don't have to spend as much time talking about this. So again, come in next week prepared to do that. Yes?
Sorry, I missed, is it, you said you were adopting references sporadically?
Yeah, so one thing I'll mention is that you will see sometimes that under week 1, 2, 3, it may say something about a knowledge check, and we may not do a knowledge check that week. Okay? So again, it's either we have time to do them or we don't. The ones that we don't have time to do, Won't have any point value towards your grade, but I may still open them up so you have practice. Any other questions about anything to do with the class? Yeah, what's up? It should be today. Yeah, I submitted everything yesterday. It has to go through some approval process. If there's anything you're not sure about, you can message me and I'll send it to you, but hopefully by today. Thank you guys for your attention. I know 7 minutes were tough. Okay, I appreciate your focus, your energy. I'll see you guys later. Have a great day.
Ooh, breakfast. Let's go.